findings are subtle. What you need to do is think about it. Poorly defined radiolucencies. This is a good technique we were shown about. You do flexion, extension, lateral x-rays, and you can see that the femur is loose. It's pistoning in and out. What about infection? Well, infection, fortunately, is very, very rare. It's interesting to hear the last session. We have, in the last 800 unis, have not had one infection. It is a major, major advantage of a partial knee. The evidence would suggest it's about a half to a third that of a total knee, but in good centers with big numbers, it's even less than that. In the acute system, the first 6 weeks, you need to open them and debride them and retain the implant. Chronic infection, that's down here, where you've got joint space narrowing laterally and you've got a pathological radiolucency. You clearly need to do a 1 or 2 stage revision. There are a number of surgical options. You can do uni to uni for dislocation and lateral progression. That's a lateral progression here, and I think you'll see an increasing number of these patients who have a good medial uni, and in about 8 years they get lateral progression, but you need to be cautious. Normally it's uni to a total. It's simple and it's recommended. So let's look at the operation. The approach is standard. You need to make the incision larger. You then need to go and look, first of all, at the femoral component. We've heard about removing components. You need to go between the bone and the prosthesis. Don't go between the bone and the cement. It's usually straightforward. You go both medially and laterally. You'll get a great view. You just need to be a bit more careful posteriorly. But normally, there's not too much damage on the femur. You've now got good access to the tibia. You then need to look at the tibia. I don't know whether, could you start this? I don't think it'll start. For some reason, this is, I think, done through a Mac, and it may not start. Could you just press on that? Thank you very much. No, it'll do it. That's fine. So again, the tibia, you need to be a little bit more careful. You can see some retained cement here. If you go right the way around it, using either osteotomes or using the Gilles saw, you will be able to remove it relatively straightforwardly. Now, the femur is slightly different, and we alluded to this. Let's see if we can start this. Don't you just love Macs? When they go from PC to a Mac, they don't tend to work very well. So let's see if that works. So the only problem on the femur, I would use posterior referencing, reference from the normal lateral side, and all you then have to do is make sure you get your rotation right. You've lost the posterior bone. There may be quite a bit of a defect there, so putting in a small little Hohmann retractor to make up for where the normal anatomy would be, you can see we've put that into there. You can then use white sides on the epicondylar axis. It's the only bit on the femur which is difficult. Tibia, don't worry, there isn't one on this one. That is fairly straightforward. You need to reference from the lateral side. I personally use IM, but you can use extramedullary or IM. You need to get the rotation correct. And I would normally go for 8 millimeters with a primary and 10 if you're revising a uni. And the poly 18 tends to be a bit thicker. So you need to beware. Some revisions are an absolute nightmare. They are really very, very difficult. This is a patient of mine. She was I think she was 50. A patient, she'd had surgery by a surgeon who, this was his second one. She has no medial buttress. She had a DVT, a pulmonary embolus, and she was in a plaster for 6 months. They can be a nightmare. So what are the results? Well, this is an independent assessment. You can see the most common failure mode is lateral progression, relatively straightforward. There's a smattering of loosenings. But if you look at the revisions, bearing exchange is quite easy. Interestingly, in the register, that's a failure, whereas if you have a dislocated hip, it's not a failure. I don't know how we can explain that. There were 3 revision knees, but in the vast majority of them, 24 cases, 21 which were converted to a primary total knee. If you look at the literature, they may be more difficult, particularly with deep defects, infection, fracture, instability. You'll need stems, augments, and increased constraint with variable outcome. Every bit as difficult as the most difficult primary. But however, most can be converted to a primary, thicker poly than usual, and the defects can either be filled with cement or with bone. Overall, the outcomes are worse than a primary, but better than a revision, and there's ample evidence to show that. But they can be an absolute nightmare. So in summary, you need to be careful with indications. Treat unexplained pain following a uni as you would with a total. Don't revise them. Beware normal radiolucencies. You have to educate everyone about them. During surgery, you need to be careful when dialing in femoral component rotation. Use white sides, line, and the epicondylar axis. Infection and failed tibial plateau fractures are difficult. You'll need stems and you'll need sleeves. Most other revisions can get by with a primary total knee, usually with a slightly thicker poly. Thank you very much.
Thanks, Chris.